This is Eric Michael Loyd, psychology, master's in neuropsychology concentration. But today I'm reading an article from a book, How to Work with Clients' Strengths. This is also regarding OARS, which is a motivational interviewing perspective, and outlines the tenets of motivational interviewing, openness to experience, affirmations, reflective listening, and summaries, using summaries. This one in particular reviews crisis intervention and solution focused therapy. A crisis can result from situational stressors, transitional changes, or disasters. The degree to which an event is experienced as a crisis depends on how the person perceives it. A crisis for one person may not be a crisis for another. A crisis occurs when a precipitating event disrupts an individual's or family's usual ways of functioning, resulting in their experiencing a sense of disequilibrium. When in this state, people experience a variety of strong feelings such as vulnerability, anxiety, powerlessness, and hopelessness. At this point, a person may resort to increasing the use of his or her usual coping strategies or trying new strategies in a trial and error manner to attempt to deal with the crisis situation. If these additional efforts are unsuccessful, the person might experience increasing tension and is at risk for major disorganization of his or her functioning. After 4 to 6 weeks, clients will, with or without treatment, experience either a return to their previous equilibrium or a new equilibrium that may leave them coping better or worse than prior to the crisis. The primary purpose of this intervention is to accelerate the return to equilibrium and at least prevent individuals from stabilizing at a new regressed level of equilibrium. There are various models of crisis intervention. One of the most complete models is the 7-stage approach developed by Roberts, 1991. Assess lethality and safety needs, establish rapport and communication, identify the major problems, deal with feelings and provide support, explore possible alternatives, assist in formulating an action plan, and follow up. Because of their disequilibrium and emotional distress, clients will often take steps that they otherwise might have resisted prior to the crisis in the process of developing new coping skills. Client change in crisis intervention is accomplished by various in-session and between-session activities. One clinician activity in the session involves challenging the client's negative self-talk or irrational beliefs by the use of carefully worded questions. The purpose of such questions is to get the client to replace the negative irrational self-talk with positive rational self-talk. The clinician also works with the client to identify alternative courses of action for successfully dealing with the crisis. After various alternatives have been identified, the clinician and the client develop an action plan for implementing them. An action plan involves carrying out specific tasks, primarily by the client, but also by the worker and significant others designated to solve specific problems in the current life situation, to modify previous inadequate or inappropriate ways of functioning, and to learn new coping patterns. Tasks are specific actions that must be performed in order for the client to achieve his or her treatment goal, reestablish equilibrium. Most tasks are performed by the client in the form of between-session tasks, homework, but some are done within the treatment situation. Successfully performing therapeutic tasks should result in the client feeling, thinking, or behaving in new and different ways. In crisis intervention, clinicians should encourage clients to think of alternative ideas, coping methods, and solutions. However, when they are under stress of helping clients deal with crises, Clinicians are often tempted to jump in quickly to offer solutions and advice. A clinician who offers advice to and generates solutions for a client may quicken crisis resolution, but does not foster client empowerment. Clients often do not respond as quickly as clinicians would like. However, clients are more likely to generate their own solutions and thus feel empowered if clinicians show patience. Perhaps clinicians would be less likely to rescue clients and more likely to reinforce client strengths, even in a crisis, if they had a specific model to guide them in such situations. One therapeutic model that lends itself to working with client strengths in crisis situations is solution focused therapy. Solution focused therapy. Solution focused therapy views change as inevitable and continuous. This approach presumes that there are fluctuations in the client's presenting problem, that it does not remain constant in severity and or frequency. At times the problem is either present or at least less frequent or intense than at other times. The task of the clinician using solution-focused approach is to work collaboratively with the client to identify what she or he is already doing that contributes to the diminishing of the problem. Solution-focused therapy, therefore, emphasizes identifying and amplifying clients' strengths and resources used in solving or reducing the frequency and or intensity of the presenting problem. This therapeutic approach assumes that clients ultimately possess the resources and capabilities to resolve their problems. Solution-focused therapy, therefore, is a non-pathologizing approach to working with clients. In solution-focused therapy, the emphasis is on finding solutions rather than solving problems. The solution-focused therapist is a catalyst for the client to enlarge and increase the frequency of solution patterns rather than decreasing problem patterns. The focus is on what is happening when things are going well instead of what is happening when the problem is present. Solution-focused therapy emphasis on strengths and solutions helps build the expectation that change is going to happen. The more the therapeutic discourse concerns alternate futures and solutions, the more clients expect change to occur. The clinician's focus is on asking clients questions that achieve solutions through encouraging change talk or solution talk as opposed to problem talk. Change talk involves clients identifying either positive changes that have occurred in the problem or exceptions to the problem, or they're no longer viewing the situation as problematic. Gingerich, de Shazer, and Weiner Davis, 1988, found that when clinicians intentionally engage in change talk, clients are more likely than 4 times as likely to discuss change in their next speaking turn. This is in keeping with an assumption of solution-focused therapy that a small change is all that is necessary to elicit a larger change, thus resulting in a positive self-fulfilling prophecy instead of a negative one. Solution-focused therapy assumes that clients really do want to change rather than seeing them as resistant. Clients not changing is viewed as their way of letting the clinician know how to help them. Asking the client to do more of what he or she is already capable of doing can strengthen the therapeutic relationship because the clinician is not asking the client to do something unfamiliar. The client is likely to get the message that he or she is okay and is not deficient or in need of fixing. According to Berg and Jaya, 1993, when clinicians focus on working with clients and respecting their way of solving problems, the clients will offer clinicians many opportunities to learn from them. Adaptation to the way clients see their situation not only is respectful, but also promotes cooperation in therapy. It is the clinician's responsibility to be sensitive to the client's worldview, frame of reference, and fit with it as closely try to fit with it as closely as possible. Solution focused therapy is appropriate for the use with clients in crisis because it is known to produce quick and dramatic changes. Solution focused therapy is also especially useful with clients in crisis because the therapist usually begins in the present and focuses on quickly developing a collaborative relationship with the client and understanding the client's view of the problem. After the problem is defined as concretely and specifically as possible, the clinician moves the focus to discussion of solutions. A basic tenet of solution focused therapy is that one does not need to know the cause or function of a problem in order to resolve it. This is consistent with crisis intervention, in which a clinician does not have to know everything about the client's problem and the goal in order to successfully provide intervention as soon as possible. The next part, a solution-focused approach to crisis intervention. The structure of solution-focused approach to crisis intervention consists of the following steps: developing a collaborative relationship with the client, listening to the client's story and defining it in the primary presenting problem and identifying unsuccessful attempts to solve the problem, first order change. 3. Eliciting the client's definition of his or her desired outcome goals. 4. Identifying and amplifying solution patterns, exceptions to the problem. 5. Developing and implementing an action plan involving between session tasks. And 6. Terminating and follow up. The solution oriented crisis worker assesses lethality and safety needs from the very first contact with the client. Assessing lethality and safety needs, however, is not listed as a separate step here because it is done through the course of crisis. The solution oriented crisis worker relies heavily on the use of questions during the interview to identify and amplify client strengths, competencies, successes, and solutions. Step 1. Developing a collaborative relationship with the client. A dictionary definition of collaborative is to work jointly with others. In collaborative relationships, there is shared ownership for identifying and working toward solutions and goals. For collaboration to occur, the crisis clinician must use a number of skills, including empathy, identifying and reflecting the client's feelings, support, acceptance, tracking, matching and mirroring, nonverbal communication, and learning and using the client's frame of reference. Collaboration is done through the crisis intervention work, but is especially important in the beginning. To facilitate collaboration, Berg 1994 recommends that the clinician should avoid confronting clients and provoking defensiveness, avoid getting into debates and arguments with clients, and, when appropriate, take a one down position and see the client as the expert on her or his situation. Page 53. This step is comparable to Roberts stages 2 and 4. In this step, the crisis worker also should immediately begin assessing the extent to which the client is a threat to himself or herself or others, or is being threatened by others. Such an assessment is certainly an initial focus and should continue throughout the crisis work. Ensuring client safety is analogous to stage 1, assessing lethality, of Robert's model of crisis intervention. In solution-focused crisis intervention model discussed here, assessing lethality, which includes ensuring client safety, is viewed not as a separate step, but as a theme throughout the crisis work. The crisis worker performs these activities as the crisis work unfolds. Step 2, listening to the client's story and defining the primary presenting problem and identifying unsuccessful client attempts to solve the problem. First order change. Although the approach described in this chapter emphasizes solutions, the first interview usually begins with the client describing the problems that precipitated seeking crisis services. At this point, the client may want to talk about the problematic situation and the accompanying painful feelings. Listening to and responding appropriately to the client's story is the vehicle for developing the collaborative relationship. The crisis worker can begin interviewing by asking, "What kinds of concerns are you having now for what kinds of concerns are you having now for you to want to see someone like myself?" Instead of using the word problem, the crisis worker may want to use concern or issue as a way to normalize the crisis event the client is experiencing. In this way, the crisis worker moves away from pathologizing the crisis and conveys the message that such an event can be a part of life, although mostly unexpected, that calls for extra effort to find a solution. A question many therapists use when beginning a first interview, which should be avoided, is, "What brings you here today?" This question can reinforce a sense of external locus of control, which most clients already are experiencing. Frank, 1982. Because all clinician work should be empowering to clients, we want to reinforce their having an internal locus of control. Therefore, we need to be careful in the language we use and how we talk with them in the therapeutic conversation. When the client mentions a number of problems, the crisis worker should ask the client to prioritize. This prioritizing could be done by the worker saying the following: "You've mentioned several problems you are having now. I find it very helpful to work on one problem at a time, whenever possible. Which of the problems you just mentioned do you want to focus on first in your work together, in our work together?" It is important for problems to be defined as specifically, concretely, and behaviorally as possible in terms of who, what, where, when, how, and how often. Part of the client's story involves describing how he or she has already tried to resolve and cope with a difficult situation. As mentioned previously, before they talk with a crisis worker, clients often have tried different ways to resolve and cope with the crisis, but none have worked, and this can result in clients feeling stuck and or in an unsuccessful vicious circle. Obtaining this information tells the crisis worker what not to try with the client, because if it has not been successful for the client so far, it is very unlikely it will be successful at all. Clients are stuck in this vicious circle because they have been trying to resolve the crisis within their existing frames. Also, obtaining this information about unsuccessful attempts to solve the problem helps to loosen up their existing frames so they will consider trying something different. Once the worker believes the client has defined the problem and the unsuccessful attempts to solve the crisis as clearly and concretely as possible, the worker should move on to asking the client to define his or her outcome goals. Some clients, however, have a greater desire to ventilate and may still want to keep focused on problem talk. When this occurs, it's best not to push clients to define goals and focus on solution talk until they are ready. Step 3, eliciting the client's definition of desired outcome goals. In solution focused therapy, more emphasis is placed on setting goals than defining problems. DeShazer, 1985. A goal describes a desired future state for the client in terms of how she or he is will be feeling, thinking, and behaving differently. Like problems, goals should be set by the client and defined as specifically as possible. DeShazer, 1988. Clients are much more likely to cooperate, not resist, in the clinical situation when the focus of the work is on their goals rather than on goals set by the clinician. Often, when clients are asked what their goal is, they might say something like, I want to stop being depressed, or I want to get rid of my depression. Goals, however, should be stated in the positive rather than in the negative. Presence rather than the absence of something in terms of feeling, thinking, or behaving, such as, what do you want to feel instead? Or, how do you want to be feeling differently? How do you want to be feeling differently? The goal setting involves clients representing themselves a future reality that does not contain the presenting problem. The more they describe in detail how they want to be feeling, thinking, and behaving differently in the future, the more real these become. Consequently, the process of asking and answering the miracle question and the follow up questions can be considered a form of unguided imagery. So that's where I'm going to leave off today. Don't want to make these videos too long, but those are the first several steps of solution focused therapy, how to work with client strengths in crisis intervention, a solution focused approach. And just to recap or state, this is by Gilbert J. Green, Mo Yi Lee, and the chapter seeks to discuss how to use solution-focused therapy in working with the strengths of clients in crisis, how to structure solution-focused strengths-based approach to crisis intervention in a stepwise manner, how to consistently engage clients in change talk and not stay stuck in problem talk, how to co-construct with clients outcome goals that include a future without the presenting problem, and how to develop a collaborative relationship and client change in ways consistent with enhancing client strengths. So, thank you for your time.